Ablation for PAF has been something that has evolved a lot over the past decade and a half, let's say. And like any new technique, when it started, it used to be this highly complicated procedure that took forever, that took literally the whole day. You would spend the whole day in your lab. You wouldn't know how the procedure would start, and you definitely wouldn't know how it would end. And I think, as with any procedure, of course, you'd like to avoid all this. You'd like to have a very predictable procedure. The intuitive advantage is it goes fast. That's what everybody thinks about. And when you say standardized, people say, let's make it faster. We worked a lot on this. We've managed to successfully integrate technology, both image integration technology and catheter technology in our workflows, and we've succeeded in building workflows that allow us to predict our procedure times to the minute. Our standard deviation of procedural time is down to 4 minutes on a total procedure time of a little bit over an hour. Now, the true benefit is actually not this time gain. It's nice, it's good to have. But as any manufacturing plant can tell you, the true benefit of standardization is you become more efficient. You become more efficient because anything that deviates from your normal workflow, provided you know what is supposed to happen, anything that deviates stands out. You will notice immediately if anything's off. So I strongly believe that standardization allows me greater efficacy and greater safety. The fact that it's fast is really nice to have, but it's a side benefit. The true benefit and the true advantage is enhanced efficacy and enhanced safety. PVC's premature contractions are an interesting phenomenon. And for the longest time, I guess most people wouldn't really be able to say whether it's a phenomenon or a symptom or something that needs to be treated, yes or no. Actually, I'd argue we still don't know for sure whether we need to treat them. But what you can point out is that from historical data, people started studying whether it made sense to, for example, treat these phenomena with drugs. And in particular, with the CAST trial, we learned that in the setting of acute post-infarction patients, giving drugs to these patients to suppress their PVCs is actually a really bad idea. It's a landmark trial. It's a landmark trial for evidence-based medicine in general. It showed us that usual conventional wisdom is not always right, that you need to do randomized trials, and it changed the field. And because of that, for example, specifically for PVCs, people still feel like, no, it's a bad idea to treat them. Look at the CAST trial, we're killing patients. That's not necessarily true for all these patients that have PVCs that are not in the post-infarct setting. And actually there's good data published 2014, 2015, meta-analyses, studies, for example, the cardiovascular health study, population study showing that PVCs actually do predict heart failure. It's not necessarily benign. It's not necessarily a phenomenon that you can ignore. It doesn't prove you need to treat them, but it does prove they are important. And then when you start talking about treating them, of course, then you have the option of giving drugs to these patients, but you also have the option of doing an intervention, of doing an ablation. And as with any technology-driven intervention, initially people are wary, they're cautious. It's new, it's potentially dangerous, may lead to complications, and there's always drugs. And we can give drugs, and we know in which patients we shouldn't, and we know in which patients it's probably reasonably safe to give drugs. Now, the thing about any technological intervention is it grows better over time. It evolves. Technology evolves, experience evolves. This is not true for drugs. Drugs, they are what they are. Nothing on the planet will ever make sotalol better. It's the drug we have, we know the data, and it's going to be like that until someone comes up with a new drug, and that doesn't happen often. But for technology, it's different. We have ablation, and every month, I'd argue, we get better at it because we gain more experience and because technology improves. So I think we're getting to the point where, at least from a study point of view, we need to reconsider this notion where people say PVC shouldn't be treated. I'm not so sure about that. I cannot prove there's a causal link between PVCs and heart failure, but I can show there is at least a correlation. And we can show that we have a highly efficient and incredibly safe technique to treat these PVCs, which is, I think, a worthwhile topic for study.